weekly and series. I'm Amy Peacock. I'm a researcher at the National Drug and Alcohol Research Centre, and I will be the chair of the webinar today. Before we start, I would like to pay my respects to the traditional custodians of the lands on which we meet today, which in my case are the Mawinia people. We pay our respects to elders past and present, and we extend that same respect to any First Nations people joining us here today. I'm really excited for the webinar that we have today. Today, we're going to be hearing about a major study that has been conducted in the Australian alcohol and drugs field over the last nearly 2 decades. We're going to be hearing about long-term patterns of heroin use and mental health, main findings from the 18 to 20-year follow-up of the Australian Treatment Outcomes Study, which is a prospective longitudinal cohort study conducted in Sydney, Australia. To give us all of these juicy findings from 2 decades of work, I am also delighted to introduce our speaker for today, Dr. Christina Marel. So Chris is a senior research fellow and program lead of treatment and translation among complex populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. Her research focuses on improving our understanding of and responses to mental and substance use disorders in complex populations and developing innovative evidence-based resources to support the translation of research into clinical practice. Chris isn't going to be alone today in sharing her expertise. At the end of the presentation, we have panel discussion. Chris is going to be joined by Dr. Jack Wilson, who is a postdoctoral research fellow at the Matilda Centre as well. Jack's research focuses on patterns of cannabis and other drug use, associated health outcomes, and implications for Australian drug policy. And Jack, too, is an expert in this cohort. We're going to have time for questions at the end of the webinar, so please do send them through. You may ask your questions using the Q&A function, please not the chat, and I will do my best to present them to the panel at the end. I've got a long list of questions that I want to ask them, but please send yours through and I will do my best to put them to them. But now I am going to stop talking because it's not me you want to hear from. I'm going to ask Chris to turn on her camera and take us through the presentation. Thank you.
Thanks, Amy. Hi, everybody, and thank you so much for the invitation to present today and also for being here. I am going to be talking about the long-term patterns of heroin use and mental health, as Amy said, using 18 to 20-year follow-up data from a longitudinal cohort study called the Australian Treatment Outcomes Study, or ATOS. I have been incredibly lucky to have worked on this study for the last 12 years. I coordinated both the 11-year and the 20-year follow-ups, and it's been one of the most challenging and rewarding projects that I have been lucky enough to work on. Before I go further, I just want to acknowledge and pay my respects to the traditional owners and custodians of the lands. I am currently on the Gadigal people of the Eora Nation, the lands of the Gadigal people, and I would also like to acknowledge the traditional owners of the lands for other people who are joining us today, and pay respects to any First Nations people who are here as well. So first of all, why are we focusing on heroin? Although there has been substantial international research and public health investment over the last few decades, opioid-related deaths have increased, doubling in the US and Scotland over the last 10 years. In Australia, some excellent research coming from NDARC has highlighted that 1/4 of drug-induced deaths in 2019 was due to heroin, which is the highest proportion in the last 25 years. So it's not surprising that heroin dependence is still associated with high levels of morbidity or mortality and a greater burden of disease than any other illicit substance. In the literature, we often see and hear the term chronic relapsing condition used to refer to heroin dependence because it has so often been associated with long-term recurrence, relapse, multiple treatment episodes, and treatment failure. But is this type of course really inevitable? In terms of what we know about heroin, and I know that for some of you, this is going to be covering what you are already very familiar with, bear with me because for others it may be less familiar, and I'm going to try to bring us all onto the same page. Opiates have a long history of both medicinal and recreational use dating back to at least 4000 BC. But we really began to see an increase in the use of these drugs in the 1800s because of 3 key events, which were the isolation of morphine, the invention of the hypodermic syringe, and the synthesis of heroin in 1874. And heroin was sold as an over-the-counter cough suppressant between 1898 and 1910, And one of the primary clinical characteristics of opioids is that they reduce pain or produce analgesia and are often referred to as narcotic analgesics. The most common form of administration is injection, but heroin can also be smoked, snorted, or heated, and the vapors inhaled. It's usually sold in caps, which is a small amount, usually enough just for one injection or shot or grams. And it can be sold cut with a mix of, sold cut or mixed with a range of unknown substances, which can make it hard for a person to know the purity of what they're taking, and the other substances can be harmful. The effects include an almost immediate rush, smaller pinned pupils, feeling drowsy or out of it, feeling relaxed, content or sedated, euphoric or high, detached, feeling nauseous, developing dependence or use disorder, including withdrawal if use is stopped, coma or overdose. Some of the physical health risks associated with use include the risk of bloodborne viruses and endocarditis, which relate to the method of use rather than the drug itself, lung infections, and overdose. And some of the long-term risks include dependence, dental issues, which is often due to opioids leading to dry mouth, less saliva to prevent tooth decay, but also dental hygiene and diet. People who use heroin are also increased risk of dying from suicide or trauma. Some of the psychological health and social risks include breakdown from relationships, problems with employment, school or study, and homelessness. There's also an increased risk of social isolation, mainly due to heroin being highly stigmatized. There are risks associated with the method of administration, which is usually injection, so skin and vein infections, endocarditis, and bloodborne viruses, as I mentioned, as well as with the risks associated with other substances that heroin can be cut with. Overdose is more likely to occur with heroin than other drugs. Heroin is a central nervous system depressant, and we know from a lot of Shane's work, accidental overdoses are common, particularly when other depressants are used. So for example, alcohol, benzodiazepines, or other opioids. Combining heroin with some kinds of antidepressants, for example, tricyclics or stimulants such as cocaine or methamphetamines, can also increase the risk of overdosing. The person is also at risk of overdose after periods of abstinence, for example, after recent prison release or long-term treatment, if they've previously overdosed and if they use alone. And if caught in time, the effects of overdose can be reversed with naloxone, but there's still the risk of serious health problems. Although the prevalence is relatively low, opioids carry the highest degree of harm. And some of the harms include premature death, with mortality rates more typical of what you might expect to see among the elderly. The risk of overdose also contributes to premature death, and non-fatal overdose is associated with serious health effects such as brain damage and cognitive impairment. Smoking or injecting heroin is also associated with poor physical health due to viral transmission, vascular damage, and pulmonary disease. Mental health is also poor, and it's been estimated that at least half of any group of people who use heroin will qualify for a psychiatric diagnosis, most commonly mood, anxiety, or personality disorders. High rates of criminal involvement are also common, as are low levels of education and high rates of unemployment. In general, people with heroin dependence are highly disadvantaged, very unwell, socially marginalized, with a large burden of disease. And this is a really long way from the images of heroin chic that I grew up with, which dominated advertising in magazines in the late 90s. Some of you might be familiar with the heroin drought that occurred in 2000, 2001. And what we know from some of the work that Louisa has led is that this had to do with the global supply of opium. So in the early 2000s, the predominant opium cultivating countries worldwide were Afghanistan, known as the Golden Crescent, who produced 3/4 of the world's supply, and Myanmar, known as the Golden Triangle, who produced 18%. Heroin cultivated in the Afghanistan region was largely trafficked through the Middle East, Central Asia, and Africa to the European and American markets. Australian heroin typically came from Myanmar region, which also supplied Canada and East Asia. There was a dramatic decrease in the cultivation of opium worldwide in July 2000, when the ruling Taliban Party of Afghanistan imposed a total ban on the cultivation of opium poppies. The high compliance with this ban resulted in a 94% reduction in opium poppy yields in Afghanistan from the 2000 to the 2001 harvest, which meant that supply reduced by 3/4. And of course, the Taliban were overthrown in September 2001. There was an increase in the cultivation of opium after that. But since the takeover by the Taliban in August 2021, the area of poppy cultivation has been reduced, and the Taliban have banned poppy cultivation, opiate trading, and processing. It appears that global opium production in 2022 has been impacted, largely due to less opium being produced in Afghanistan, and the 2023 harvest is likely to be even smaller, but more time's needed to see how these reductions are going to impact the global heroin market. This graph shows really nicely how the 2001 heroin drought was primarily due to the production of opium in Afghanistan and the beginnings of the reductions in production in 2022. So why was Australia impacted by the heroin drought if most of our supplies came from the Golden Triangle? Again, from Louise's work, we know that there were a number of factors that contributed to the supply disruption alongside the decrease in production in Afghanistan. And I could be here all day and nobody really wants that. These include events such as increased funding to the Australian Federal Police and Customs as part of the illicit drug strategy, which meant that the risks of importing heroin were greater. So Australia was seen as less attractive to key heroin suppliers. It's also believed that the heroin shortage was probably caused more by changes in heroin supply to Australia related to Australian drug law enforcement, rather than to natural events such as changes in heroin production. But regardless, the availability of heroin in Australia did decrease. There was a delay in being able to purchase heroin, which resulted in increased prices in some Australian jurisdictions and a decrease in purity. There is a belief in some circles that since the heroin drought, it's not really a problem anymore, but this is not the case. As you can see, the estimates of lifetime heroin use in the general population have typically hovered just below 2%. But what's really interesting is if we consider the probability of developing opioid use disorder by looking at conditional probability estimates. And this means the proportion of people who have used opioids who will then develop opioid use disorder. Analysis we conducted a few years ago using data from the 2007 National Survey of Mental Health and Wellbeing showed that almost 1 in 2, or 45% of people who had used opioids 5 times in their life would go on to develop opioid use disorder, with half of all cases developing within 2 years after onset, which for opioids was a median age of 20. Realize that's a lot of information, but in other words, the steepest transition from use to use disorder was found for opioids and stimulants, with 47% of people who had used opioids likely to develop opioid use disorder within 12 years after first use. So what can be done? In terms of available treatments, in general, treatment falls into 3 categories. Firstly, detoxification, which is a short-term intervention that removes toxins from the body. It deals with the physical side of dependence, and withdrawal is managed in inpatient or outpatient environments. Drug-free residential rehabilitation is a long-term holistic treatment which follows a period of detoxification where residents are unmedicated. Residents change their lifestyles completely, and that involves abstinence from drugs, developing employment skills and self-sufficiency. And programs are usually between 3 and 12 months. Maintenance therapies or pharmacological maintenance involve outpatient opioid substitution therapy, and that's usually the most popular treatment. Methadone or buprenorphine essentially replaces heroin, and although heroin can still be taken, larger amounts are needed to gain effects because of the methadone's blockage of opioid receptors. Buprenorphine or Subutex has been available in Australia since 2001, and it's increasingly popular. Suboxone is a combination of buprenorphine and naloxone, which is the drug responsible for reversing opioid overdoses. And naloxone is only activated when injected, and that will induce acute opioid withdrawal. Both methadone and buprenorphine have longer half-lives than heroin, which means that people can receive their dose daily or every second day. Buvidal and Sublocade became available in 2020 as depot injections of buprenorphine, Buvidal as weekly or monthly injections, and Sublocade monthly only. But it's important to remember, as with other treatment approaches, there's no best method, no one type of treatment that will suit everybody, and people will often need to try a number of approaches, a number of options before finding one that suits them. And this brings me to the Australian Treatment Outcome Study, or ATOS, which began in 2001-2002 as a prospective longitudinal cohort study led by Professor Marie Thiessen. ATOS is one of the few studies to have a sole focus on heroin dependence alone. The cohort consisted of 615 people, which was made up of 535 people who were seeking treatment, recruited from 19 treatment agencies around Sydney. A comparison group of 80 people who were not in treatment were also recruited from needle and syringe programs. The treatment cohort consisted of 201 people entering maintenance programs, 201 people entering detoxification, and 133 people entering residential rehabilitation. The initial aims of the study were to describe the characteristics of people seeking treatment for problems associated with heroin use in Australia, describe the treatment they received, and examine treatment outcomes and costs at 3 and 12 months after commencing treatment. The cohort's been followed up at 3 months, 1 year, 2 years, 3 years, 11 years, and 18 to 20 years. I just want to point out that the mortality rate at both 11 and 18 to 20 years has been substantial. Before I go any further, I just wanted to set the scene a little bit and give this a bit more context, because it's so easy for me to say that this study's been going for 20 years like it's nothing. But I just want to ask you all to take a second to think about what you were doing and where you were 20 years ago. I did think about putting a picture of myself here, and then I decided not to. But I have instead put some pictures of some chart-topping songs of the time, as well as some of the big movies of the day, which of course include the first Harry Potter and Lord of the Rings movies. And of course, 2001 was dominated by the events of September 11. This is our original ATOS team. Hopefully there might be some people there that are recognisable. And we have Marie Thiessen, Shane Dart, Kath Mills, Joe Ross, Kate Hetherington, Alice, Anna, Sandra, and Ev Wilhelm. And some of the 11-year follow-up team, that includes Sonia, along with the 18 to 20-year team on the right. So sometimes when I present about ATOS, I get asked about our follow-up rates. I mentioned earlier that I've been very lucky to have worked on this study and what a challenge it has been. When I first started coordinating ATOS, I was working on the 10 to 11-year follow-up, which was around 2012. My goal at that time was for us to find as many participants as we could, which of course is the goal for any longitudinal cohort study. And for us, that meant to get as close as possible to the previous follow-up rate, which we achieved at 3 years. At 11 years, despite having no contact with our cohort in 8 years, we ended up exceeding the 3-year follow-up rate, which was really testament to some of the excellent relationships that the original research assistants had developed with participants over the first 3 years of the study. And in fact, even at the 20-year follow-up, some of our participants were asking how our research assistants were, who they hadn't seen in 17 years. At this follow-up, we had the additional challenge of COVID, which came along midway through our follow-up period. A big part of our follow-up methodology has always involved visiting services, door knocking, getting out and about. So the lockdowns made locating people a little bit more difficult. But luckily, this follow-up took place when it did, or I don't think we would have been able to find as many people as we ended up finding, given that we had to do a lot more online work. And it's really lucky for us that so many of our participants did have an online presence. When we were able to get our team together in the office, we did a lot of brainstorming, which was really productive for us. One of the ways we've been able to keep our follow-up rate so high is through the incredibly comprehensive contact and locator information that we collected at baseline and updated at each follow-up point, which takes our RAs a lot of time. But the work's always been worth it. Even with COVID lockdowns, we were able to locate, as in interview, confirm deceased or speak to, but not necessarily lock in an interview, 95% of the cohort this time. In terms of where we found people since baseline, I have this map to illustrate some of the global spread of participants since we first started the study. While everybody was interviewed in Sydney in 2001, 2002, the follow-ups have been conducted with people across Australia and New Zealand, the Middle East, Europe, Scandinavia, and the USA. Unfortunately, not in person. From the first 11 years of ATOS, we've learned that heroin use, dependence, and other drug use reduced over time. There's also been substantial reductions in risk-taking, crime, injection-related health problems, and improvements in general physical and mental health. Positive outcomes were associated with more time spent in maintenance pharmacotherapies and residential rehabilitation and fewer treatment episodes. But time spent in detoxification has not been found to be associated with positive outcomes. Major depression has been consistently associated with poor outcomes. But we didn't know what would happen over the longer term, with longer term patterns of co-occurring mental health and substance use unclear. We also didn't know what would happen to substance use around 20 years after people entered treatment, which is about 30 years after substance use initiation, we also didn't know what would happen to people's mental health. At 18 to 20 years, ATOS participants were in their late 40s, which is a critical period of transition associated with increased risk and prevalence of developing chronic disease. So with this in mind, we wanted to examine patterns of substance use, psychiatric health, criminal involvement, mental and physical health of ATOS participants over the 18 to 20 year study period, and ascertain whether any demographic substance use or treatment factors were associated with outcome. And that's what I'm going to be talking about from here. Our cohort was fairly typical of people presenting to treatment for heroin dependence at baseline, which is to say they were 2/3 male, around 30 years old, and they had been using heroin for around 10 years. Around 1 in 4 reported crime as a main source of income in the last month, and just under 1 in 8 were living in unstable housing, meaning a boarding house or hostel, a shelter or refuge, or no fixed address, including couch surfing. At 18 to 20 years, the cohort re-interviewed were broadly representative of the initial baseline sample. Again, roughly 2/3 male with a mean age of 47. Crime as a main source of income had reduced to just under 4%, and less than 2% of participants reported living in unstable housing in the last month. At baseline, there was quite a lot of polysubstance use, and almost everybody was heroin dependent by nature of the study. Around 1/4 of the cohort met DSM-4 criteria for a diagnosis of current depression, and almost 1/3 had PTSD. At 18 to 20 years, the mean number of drug classes used in the last month was 2. Heroin dependence had reduced to 15%. 1 in 7 participants had past month major depression, and just over 15% had PTSD. I won't go into too much detail here, but over the 18 to 20 years, all participants spent some time in treatment for heroin dependence, with a median of 6.5 years of treatment over a median of 6 treatment episodes. In terms of the types of treatments that were being accessed at 18 to 20 years, the majority were receiving methadone maintenance, both GP and clinic-based, with a smaller proportion receiving Subutex or Suboxone. In terms of substance use, there was a high amount of polysubstance use, both at baseline and 18 to 20 years. But it should be noted at 18 to 20 years, 3/4 of participants had not used any heroin in the last month, and less than half had not used any illicit drugs, and that included heroin, cannabis, amphetamines, cocaine, and hallucinogens. In terms of patterns of heroin use, dependence, and other drug use, these all decreased over the study period, with the most dramatic reductions evident in the first 3 months of the study. For the most part, these reductions were maintained over time, with the exception of other drug use, which had returned to almost baseline levels by 18 to 20 years. Alongside reductions in heroin use, daily heroin use reduced over time, with 6% of participants using heroin daily at 18 to 20 years. In terms of abstinence from heroin, the vast majority had experienced at least 1 month or more of abstinence in the last 20 years. The mean longest period of abstinence was just over 10 years. In terms of injection-related health and needle sharing, these both decreased over the follow-up period, again, most dramatically in the first 3 months. The proportion of people who had overdosed in the 12 months before their follow-up interview decreased significantly from baseline to 11 years. Again, most dramatically in the first 3 months of the study, and then these were maintained throughout the study. Of those who had overdosed in the last 20 years, just over 40% had been given take-home naloxone, mostly injection form. Three-quarters of those who had been given take-home naloxone said they'd been trained in how to administer it. I wanted to show you the estimated years of life lost for the ATOS cohort. Before I do, I wanted to tell you that this analysis was conducted just after the 11-year follow-up in 2016. We have not yet updated it with data from the 18 to 20-year follow-up. The reason for this is because these data come from linkage to the National Death Index. Due to record lags, we like to wait a couple of years after the study completes before we perform this linkage. So in 2016, after the 11-year follow-up, we ran the analysis in 2 ways to estimate the years of life lost for the ATOS cohort. Firstly, based on average life expectancy of 65 years, which is the age when people used to retire. So this shows that the youngest person in our cohort died when they were 20 years old from an overdose. Based on average life expectancy of 65 years, the years of life lost for this person was 45 years. The next person who died was aged 22, also from an overdose. Based on average life expectancy of 65 years for everybody who died in ATOS, in 2016, the total years of life lost in the cohort was estimated to be 1,988 years. We know that's not actually the case. In Australia, the average life expectancy is actually closer to 85 years. Based on that calculation, the total years of life lost was 3,135 years. Again, this hasn't yet been conducted on the most recent follow-up data, which is why the total number of people who've died on this slide is lower than what I showed you earlier. But given we have had so many people in our cohort die, I did want to show some preliminary mortality analysis we've conducted. Again, just to stress, these are preliminary and will be confirmed once we have completed data linkage with the National Death Index later this year. What I have here was based on a search that we ran just before we started conducting the 18 to 20-year follow-ups. We have more information through interviews that another 2% or 20 people have died during the follow-up period. As I say, we'll be looking into that in more detail later this year. So our unknown circumstances of death and the total number of those who've died is likely to be much higher than reflected here. Based on the last known information, most deaths were due to overdose, which was attributed to accidental as opposed to intentional overdose, though of course it can be difficult to ascertain. In terms of factors that were consistently associated with heroin use, heroin dependence, and other substance use over time, we found that major depression, detoxification, and not having commenced residential rehabilitation were consistently associated with heroin use. Heroin dependence was consistently associated with major depression, BPD, detoxification, and not having commenced residential rehabilitation. Other substance use was consistently associated with being male, major depression, BPD, maintenance therapies, and not having entered residential rehabilitation. Important to note here is that major depression was common to all 3, as was not attending residential rehabilitation. In terms of factors that were consistently associated with overdose over time, we found that overdose was associated with screening positive for BPD, meeting criteria for a diagnosis of ASPD, having spent time in detoxification or residential rehabilitation. Those who had spent time in maintenance therapies were less likely to have overdosed in the past 12 months. In terms of the overall picture of mental health, starting with severe disability over time, we found that while there was a significant improvement in mental health severity over time, again, most dramatically in the first 3 months of the study, there was little change in physical health severity over the study period, with 18-year severity slightly worse than baseline levels. In terms of factors that were associated with improvements in general physical health over the study period, meaning there was a consistent and enduring relationship over the study, we found that being male, younger aged, the absence of PTSD and major depression, and having entered residential rehabilitation were associated with improved general physical health. Being male, younger aged, the absence of major depression and BPD at baseline, and not having entered detoxification were consistently associated with improved general mental health over 18 years. Important to note here is a commonality of major depression over time. In terms of major depression, this decreased significantly between baseline and 3 years, again, with the most dramatic reductions evident between baseline and 3 months. 11 years it had increased a little bit and then decreased again at 18 years. So I've mentioned major depression quite a few times now. Over the 18 years, DSM-4 major depression was consistently associated with heroin use, dependence, other substance use, injection-related health problems, needle sharing, criminal involvement, physical health, and mental health. So what does all that mean? It's a lot. I know that I've presented a lot. Some key take-home messages, some key findings. First of all, the mortality rate over the study period, over the 18 to 20 years, was devastating, with just over 1 in 6 participants deceased, which is unacceptably high for people whose mean age was just 47. Secondly, over the study period, major depression was the single most influential factor for poor outcome, and it was significantly associated with almost every outcome that we examined. Those who were depressed were consistently more likely to be using heroin and other substances, be heroin dependent, be sharing needles, experience injection-related health problems, be involved in crime, and have poor physical and mental health. Now, we have effective treatments for major depression, both as a single disorder and in the presence of comorbid substance use disorders. But the persistence of this relationship between major depression and poor outcome really suggests that we need to be better at making sure evidence-based treatments are being provided to the most vulnerable when they need them. Major depression also had a stronger relationship with heroin use, heroin dependence, and poor physical and mental health than any other variable we looked at. At 18 to 20 years, participants were in their late 40s, which we know is a critical risk period associated with the increased risk and prevalence of developing chronic disease. Many people were experiencing poor physical health and multiple comorbidities. As the cohort continues to age, there will be a need to develop and deliver comprehensive treatment, which has the capacity to address both mental and physical health needs. Commencing residential rehabilitation was consistently associated with positive outcomes, and it was the only significant treatment factor related to improved general physical health. This might reflect the capacity of residential settings to provide a more holistic and comprehensive treatment approach, which can address the physical health of people with heroin dependence. And interestingly, while residential rehab was largely associated with improved outcomes, the inverse relationship was observed for overdose, where resi rehab was consistently associated with increased odds of experiencing overdose. While the rates of overdose decreased over the study period, the importance of overdose prevention strategies for people with heroin dependence really can't be overlooked and highlight the need for comprehensive and assertive aftercare following treatment discharge and prison release. And these findings, of course, are in line with others that have highlighted the increased risk of overdose due to reduced tolerance following periods of abstinence, such as treatment release and release from prison, and emphasize the importance of providing psychoeducation regarding reverse tolerance and other harm reduction measures like take-home naloxone, training in its administration and supervised injection sites, in reducing the risk of opioid-related fatality. While detoxification was associated with reductions in heroin use over the short term, it was related to poor outcome over the long term, which highlights its importance as a gateway into additional treatment rather than a standalone treatment in itself. These findings are also strong evidence that clinically significant levels of improvement can be achieved and maintained over the long term, and also point to the importance of longitudinal research and that we really need to be doing more to understand what's behind these turning points or potential risk periods of relapse or remission that can be targeted. In terms of where we go next, I mentioned how important longitudinal studies are in informing our understanding of risk periods that can be targeted. As an example, I have on screen here long-term patterns of trajectories in heroin use that we last conducted with the 11-year data. Hopefully you'll be able to see that there are 6 patterns of heroin use over the study period, and perhaps notably, one group that demonstrated no decrease in heroin use over 11 years, which is the red line, and one group that decreased their use over the first 3 years of the study, then maintained abstinence, which is the pink line. What was extremely important in terms of furthering our understanding of whether heroin use is, in fact, a chronic relapsing condition, is when we examined the joint trajectories of heroin use and treatment over the same period of time, and found that a substantial proportion of people were able to achieve and maintain abstinence without the need for ongoing treatment. And that is shown on this ridiculous looking thing here, which is the joint trajectories of both heroin use, and that's the bold lines, and treatment utilization, and that's the dashed lines over the first 10 years of the study. In this analysis, we found the group with the highest joint membership was the one made up of the rapid decrease to maintain abstinence heroin use and the reduced treatment groups. For this group, which held 13% of the cohort, the probability of heroin use decreased as treatment utilization decreased until there was maintained abstinence from heroin with no treatment utilization. Interestingly, the group that held the next highest proportion of participants was made up of those who showed no decrease in their heroin use over the first 10 years of the study, but their treatment utilization remained high. This is not reflecting any failure of the people in this group, but more reflective of the failure of treatment to be sufficiently effective for this group. So one of the things that we'll be looking at into next will be exploring how these patterns and relationships have evolved over the longer term. As an example of what we would not know if not for longitudinal studies, if we had stopped the studies after the first 3 years, we would miss out on such a great deal of diversity in terms of fluctuating patterns of heroin use. So what we can learn from where these trajectories are going to go next is something that we are going to be looking at with great interest, and that analysis is currently underway. As part of the 18 to 20 year follow-up, we also conducted comprehensive physical health assessments on 130 people. As I mentioned, we know participants are at increased risk of developing chronic disease. So it's critical that as the cohort continues to age, we have more information on what their physical health needs will be, which we can now start to explore in greater detail with so much prospective data on people's use over time. So I won't go into detail about this, but I just wanted to mention a few key findings that have emerged from the physical health assessments. This work is being conducted as part of Dr. Chris Tremonti's PhD. Among the sub-cohort who undertook the physical health testing, there were high burdens of disease, high rates of easily treatable diseases. 25 participants had active HCV, none of whom had sought treatment. 11 were aware of their status prior to testing. And I really encourage you to check out Chris Tremonti's recent MJA paper for more information on this, with findings suggesting that treatment hesitancy may play a key role in reducing treatment rates. We know that weight is a key risk factor for cardiovascular outcomes. The majority of the subcohort were overweight or obese, with the mean BMI of the subcohort being 29. There is evidence in the literature that methadone has been associated with weight gain, and it's unknown whether this is transient or lifelong. This was also found in our study, with the mean BMI of participants on methadone higher compared to all participants, as well as those on buprenorphine. We found that 12 participants were diagnosed as having diabetes, and 4 of them were unaware, so they were new diagnoses. And the majority of those with diabetes were currently smoking. Quite a few warranted treatment with omega-3 and statin therapy. Now, as I mentioned, there were many more assessments that we conducted. What I've shown here is just a fraction of the tip of the iceberg. So I really encourage you to check out, as well as the MJA paper, Chris Tremonti's recent presentation, which was part of the DARIA series in July, if you haven't already, and he discusses these findings and other physical health outcomes in more detail. So in sum, if I can go back to what I initially started with when I started this presentation, which is heroin dependence the chronic relapsing condition, which is inevitably associated with long-term recurrence, relapse, multiple treatment episodes, and treatment failure? Well, I think not necessarily, and certainly not for everyone. In our cohort, over 80% demonstrated some level of improvement over time, and at 18 to 20 years, 3 in 4 had not used heroin in the last month. But as I say, there's much more to explore, so stay tuned. In addition to these findings, I just wanted to mention some other things that have come from this study. Given that the ATOS cohort is quite unique in terms of complexity, with many participants experiencing severe mental and substance use disorders over a number of decades, the study has led to the development of other treatment trials, including PTSD among adults and adolescents, which have aimed to intervene earlier before people reach the pointy end of these complex conditions. And that work is being led by Catherine Mills. And depression, with a trial of behavioural activation treatment for co-occurring depression and substance use disorders relative to treatment as usual for substance use, and that was led by Joanne Ross. ATOS has also contributed to 4 completed PhD projects, and there are 4 currently underway. Even though this is a lot, there is such a wealth of data available and so much that we haven't even begun to look at yet. And there's so much more to study and much more that can be done. So feel free to get in touch. Just would like to acknowledge before I finish and thank the ATOS participants over the last 20 years, the staff from AOD agencies, NSPs, NGOs, and other organisations who've been so helpful in assisting us over many, many years contact and locate participants. Of course, our funders, and in particular, RPA Hospital, the many medical and non-medical staff who helped us with our health assessments at 18 to 20 years, the many research assistants who've worked on the study over the past 2 decades. Thank you.
Thank you so much, Chris. That was a fantastic presentation. I feel like I'm still processing it all. There's so much unique, fantastic insights there, and I think some really positive findings. But that you know, over 3,000 years of life lost is just so stark, particularly when thinking about the fact that overdose was the primary cause of that loss of life. So yeah, some positives, but some very important messages there. And huge credit to you and the team. I'm a bit sad you didn't put that picture of you in 2001.
No, you're not sad.
It was nice to see some familiar faces. So yeah, huge credit to the whole team. But on that note, I am going to invite Jack to turn on his camera. Jack, obviously you've been involved in this project. Your name that was listed there as one of the PhD students who have successfully worked their way through ATOS. What are your reflections on this presentation, take homes?
Yeah, thanks for having me. I think Chris has done such a brilliant job of covering the breadth and depth of ATOS. I was 10 when ATOS started, so I sometimes feel out of depth when I'm talking about it. But I guess if I was to narrow down a few things that I would like to talk about, I think one of the things, and Chris did mention it, was the impact of COVID. You know, we collected data for the 18 to 20 year follow-up between September 2019 to September of 2021. And COVID and those restrictions were sort of smack bang in the middle of that. And as Chris explained, this sort of made it more difficult to contact and locate those participants, given that some of the services by which we would contact them, such as courts or clinical services, were limited or restricted. And it also stopped face-to-face interviews for a period of time. And that was quite important because that sort of limits our ability to continue that connection that we have with participants, which is so unique to the ATOS study. So we were sort of reduced to doing all our interviews over the phone for those periods. But more importantly, it had quite a significant impact on the participants and their lifestyle. We were pretty quick to sort of add a bunch of questions around the impact of COVID, and it was clear that they had, you know, limited access to treatment services, high rates of isolation, limited access. I think 47% said that they had limited access to doctors or specialists or surgery or any sort of social services. And a majority of participants said that there was some sort of concern about how it would impact on their financial situation and healthcare. And I think most interestingly was around 30% claimed that COVID had such an impact on their drug use. I guess that's sort of expected, but so the themes that we saw was that COVID sort of increased, you know, alcohol and cannabis use, which may be sort of maybe in response to dealing with stress and coping, but also sort of a reduction in heroin use, mainly around availability. One participant did, however, mention that they were panic buying heroin in case the quantity and quality went down. So that was quite interesting. But concerningly, we also had reports of reusing needles because of limited access to injecting equipment. We had chemists and other services that were providing bulk equipment that had closed down or had limited hours. So that was quite concerning. And then another thing that I would just like to briefly touch on is what my PhD looked at, and that is the role of cannabis use among the ATOS cohort. There's sort of increasing interest in the US and Canada around the role of cannabis in potentially curbing heroin use and the health burden associated with heroin use. As Chris showed, past month cannabis use was common at baseline, around 68% of reported using in the past month. And although this went down, it was still 40% by 18 to 20 years. We included additional questions around cannabis use. So around 1 in 10 had a cannabis use disorder at 18 to 20 years. And we also looked at the types of cannabis that they were using. So around 80% reported high potency indoor cannabis, which is quite consistent with greater populations. But when we're sort of getting around into the nuts and bolts around the role of cannabis, we looked at whether there was a long-term relationship between cannabis and opioid use throughout the 7 follow-ups, but we found we did not find a consistent relationship between cannabis and opioid use. We also didn't find that cannabis use predicted nor was associated with any treatment trajectories. So that sort of goes against claims that that cannabis use may be able to help with retaining people in treatment for opioid use disorder. So although cannabis use was common, our research sort of found no evidence to indicate that cannabis would impact on any of those major outcomes.
Thanks for that summary, Jack. That's, again, I feel like I'm processing so much of that as well. And just one of the questions I want to ask is what's next for the cohort? And you talking about cannabis made me think about that, particularly with the shifts that we're seeing, medicinal cannabis, decrim, etc. What may come next? But I think my questions are potentially at risk of not being asked because there's a lot coming through in the chat. So I'm going to try and pick some of these to ask them. Let me have a look and see. So there were a few questions around heroin use and depression. And I guess, was it that heroin use preceded depression? Like is there a bidirectional relationship there? Do you think there's any insights that we can learn from the cohort around that link between heroin and depression? Chris, do you want to kick off on that?
It's a great question. And I see there's also a similar type question about PTSD and trauma. We have not explored, I guess, the temporal relationships of onset in this cohort. So we can't necessarily establish for this group of people whether depression has led to heroin use or heroin use has led to depression, but it certainly could go either way. We know that from mental health and substance use that it does go both ways. This time, we did actually ask about childhood trauma. We have not looked at that data yet. There is, as I say, so much more to do, and there's only so many of us in the team. But we do really need to look further into that and see whether we can start to pull apart that data a little bit more to see whether any of the childhood trauma has led to substance use. But with the depression, I don't think we can pull that apart for this cohort. Jack, am I wrong with that?
Yeah, no. I agree with that. Yeah.
Okay, all right. And then we've got I think that the findings around resi rehabs have really intrigued people as well. So Paul asking, a lot of resi rehabs require cessation of maintenance treatment. If this was to change, do you think we could get the best of both worlds, improve physical health and a reduced risk of overdose? Any thoughts around that from the cohort?
Sorry, could you ask that question again?
Yeah, so a lot of resi rehabs require cessation of maintenance treatment. If this was a change, so if people could, I guess, be in rehab and be on their maintenance treatment, do you think that, we may see bigger gains for people there, both in terms of physical health and overdose?
I think from memory, that people did quite well in terms of physical in resi rehab was associated with most improved outcomes across the study. Where there was a small change was in terms of overdose, and that's really associated with lots of consistent with other findings about reduced tolerance. The same with prison and other times that people are not using anything. I think that if what was the first part of the question? Sorry, I'm not doing very well with this one.
No, that's okay. I guess what they're saying is there a way possibly that we could combine both resi rehabs and maintenance treatment?
Right.
I think is there a case that could be made for that? in terms of better outcomes potentially?
Yeah, I think that would not be a bad thing. I think it's just, and like I said, earlier in the presentation, lots of people respond differently to different things that have different needs. There would certainly be a place for that, I think.
Yeah. And I might jump on that, Jack, because I know you
Yeah.
did some work looking at trajectories of treatment engagement.
Yeah.
And just really keen to hear, because like you've talked about, Chris, that personalizing or trying different options to see what fits best for people. Do you have any insights from that work around people's experience moving in and out of treatment?
Yeah, I mean, as so my work on the trajectory is extending from Chris's brilliant work beforehand on these. I mean, we seem to continue these trajectories. But yeah, and it seems like, methadone sort of seems to predict sort of this long-term sort of coming off long-term stable treatment, but as we have talked about, that our participants are going in and out of different treatment episodes and different treatment modalities. So it's difficult to sort of make any conclusions around the efficacy of certain modalities. I think just coming back to that question before is, I definitely do think that a better coordination of treatment is the key there. And I think that sort of goes into another question that was put forward, and that's around detoxes and whether it doesn't seem like there was that transition from detoxes into other modalities of treatment. And I mean, we did see participants with, numerous episodes of detox, and so I think when we're sort of reflecting on that, we sort of want to emphasize the importance of treatment coordination.
Yeah, I saw that question too, Jack, and wanted to there are so many questions that are coming up that we're not keeping on top of them all, sorry. And very happy to put my email in the chat and have anyone contact us afterwards as well. And also I meant to send a link to the main outcomes paper that this talk is based on. We can include that in the follow-up email, I think. Amy, you said, sorry, going off on a tangent here. In terms of the question about detox associated with poor outcome and whether people necessarily transition from detox to resi rehab, that didn't necessarily always happen. We did find a lot of participants who had multiple detox treatment episodes, but didn't always then follow that up with resi rehab. And like Jack said, that didn't happen for everybody, but for some people, it was not a coordinated process where detox then led to residential rehabilitation.
Okay, so I think this is really interesting, because that was going to be a question I had for you. This is labeled as a treatment outcome study. What does it actually tell us about treatment outcomes? But I think
that's how it started, I think, at baseline, but because then it's now a natural study of heroin dependence, I think, that we can't, Sorry,
but it still gives us really important insights about how we can improve the treatment experience for people, I think, from what you've learned.
And I think that's sort of a big distinction between ATOS and a lot of the other studies as well, is like a lot of the other studies will like everyone in their sort of treatment lanes, and they're quite short follow-ups, or but I guess that ATOS has really just sort of progressed into quite a naturalistic study, and whether there are pros and cons on both sides, I think they both have plenty to offer.
Where has the time gone? We need another half an hour. There are more questions coming in, and sorry, I'm going to be selective here. There was one question I spotted, I can't find it now, about whether you're aware of anyone who's entered into aged care facilities, and I'm picking that one because I was interested in this as well. But just as there is like the cohorts in their 40s, 50s now, we've got this whole aging cohort phenomenon as well. Like, are you seeing people entering into aged care? What's the idea in terms of trying to tap into and inform our understanding and how we respond to this cohort as they move into older age?
It's such an important question, because we know the mean age is 47, but of course there are older people. There are people in their 60s, not a lot, but a few who are in their 60s in this cohort. And what we really wanted to be able to do was inform what they need in terms of their whole health, not just heroin, but what treatment needs are, what their life needs are. There was nobody that I was aware of that we followed up who were in aged care. That doesn't mean that now, a couple of years after we finish the follow-up, they're not in aged care now, or they don't need it. And that's also why we need to follow them up again to see what's going on, where they are, and also why we need to finish doing all the physical health assessments that we collected the data on to find out what their needs will be going into the future. But we do know from a lot of this work, plus a lot of Shane's work, is that people with heroin dependence, they have accelerated aging. They are 40, but they look 60, in terms of their whole physical health. So I would not be surprised if there are increased physical health needs, and the physical health was so poor this time too.
All right, and so that's a call for more waves of the study, I think.
Yeah,
is that correct?
Definitely, I think so.
Yeah. And thank you all for the fantastic comments that are coming through. And I can see there's even a few people here who've said that they would have loved to have participated in this data. So look, maybe there needs to be a new recruitment intake as well, given how much valuable information. I'm going to go for one final question. I'm so sorry, but Chris is going to put her details up so you can follow up with all of these questions. But another interesting one, is there any data in relation to Aboriginal people? Interested to know about intergenerational trauma and how that might have been factored into the study.
It's a very good and important question. We did have Aboriginal people as part of this cohort, but not specifically in relation to intergenerational trauma. But it is something that we as in all researchers need to be considering as part of our research. Jack, I can't remember whether that was specifically mentioned as part of any of the trauma types.
No, I don't think it was.
I don't think that we've gone into that data in detail yet either.
Yeah.
But it's something that we have yet to look at.
Yeah,
Okay.
definitely. Yeah.
So it sounds like if anyone's interested in doing a PhD, I think we've come up with about you've got 4 or 5 topics ready to go there. Very important topics that we need insight on, but it's 2 minutes to 4.
And I would just add that this time around we and Chris is looking at it now, those sort of lifestyle of events that may have happened. So birthdays, celebrations, deaths in the family, deaths among friends, relationships, those sort of turning points. So we're able to collect that data this time around, and it'd be really interesting to see what kind of impact that has had on the life course.
Yeah.
I'm going to be cheeky and put my email address back up because I know there's lots of questions we didn't get to. So please feel free to contact us.
Yeah.
Sorry, Amy.
That's okay. Details are there. We'll put them in the chat. We'll send them in an email afterwards, and we'll send the link to the paper as well. Hopefully, because as someone who's just recently read it, it is a fantastic read. But we are at the end of the webinar. I think we're going to briefly mention some of our upcoming webinars. But before I do, Chris, thank you so much for the presentation. So much food for thought and has really captured the attention of so many people. Jack, your insights have been fantastic. Thank you so much. And in terms of upcoming events, I'd just like to remind everyone that we have, and here it comes, Ben Reardon. Now, I don't know if anyone's seen Ben Reardon present before, but he's one not to be missed. He's going to be talking on the winds of change, alcohol, media, and emerging technology. And that is on Thursday, 28th of September. I'm so excited for that. And then Friday, 27th of October, save the date, or maybe just register because it's open now. We have our 2023 NDAC Annual Research Symposium. Come along in person in Sydney, or you can join us online and watch it all. Again, thank you so much, Chris. Thank you, Jack, and thank you all for attending. Have a good afternoon.